is going to be a short understanding of what the current evidence stands at range of motion, weight bearing and bracing after ACL surgery, and then some questions to the panel. So we're chasing some targets after ACL surgery. So that's protecting the surgical repair, restoring knee stability and range, stiffness and muscle atrophy, preventing that, and returning to normal function. How do you progress that? This is just Varun, Manek collating some data from JOSPT and certain recent articles that says that without a meniscus repair, a plain ACL, you target up to 90 at 2 weeks, and then you get full extension and more than 120 degrees flexion by a month, and near full range of motion at 6 weeks. And with a meniscus repair, you just put in another 2 weeks. So go slow by 2 weeks. As far as weight bearing is concerned, without meniscus repair, the current evidence says immediate weight bearing is allowed as tolerated with support if needed, and full weight bearing without any bracing, nothing by around 2 weeks. With meniscus repair, you can go non-weight bearing or partial up to 2, 4, 6 weeks, debatable, and then progress weight bearing to full at 6 to 8 weeks. As far as bracing guidelines are concerned, there's a lot of level 2 and 3, 3 and 4 evidence, but a systematic review and meta-analysis conclusion is inconclusive. So we really don't know how these braces are helping and how much they help after ACL surgery. So the key rehab milestones are 4. In the first 2 weeks, you protect the graft. In the 2 to 6 week period, you strengthen the quadriceps, get full range. Between 1.5 and 3 months, you work on more balance and improve the strength. And then on from 3 to 6 months, you start low intensity plyometrics, neuromuscular training, sports specific drills, etc. And you sort of think of returning the person to his favorite sport between 9 and 12 months and 15 months whenever they are ready. So what are the problems that we already know of? We know that delayed range of motion and more immobilization is going to lead to stiffness and arthrofibrosis. Prolonged bracing, too much of bracing and long knee braces are going to lead to quadriceps weakness. If you return to sports too soon, then you're risking re-injury. And the only one which is iffy is if you're doing these crazy meniscus repairs, how much of weight bearing is allowed, should be allowed, shouldn't be allowed. Some recent evidence says that early weight bearing is improving for functional outcomes, so don't hold back weight bearing for sure. Bracing in the very long term, in terms of reducing the risk of re-injury after returning to sport, it doesn't have much benefit. When you're considering return to sport, think of function, how the functional testing is more than actually the time frame of 6, 9 months, 12 months. And meniscus repair and weight bearing, even if you're doing crazy meniscus repair, early weight bearing may actually be allowed in some cases. So that's the end of that. And then now we move to the panel. So we have a nice collection. There's an orthopedic surgeon. Sandeep's working with Maharashtra Olympic Association, a lot of athletes that come from lesser backgrounds. Chandan's at HN and working with hoity-toity patients. And Krupa is seeing patients from all across in private practice. So maybe first question to Sandeep, that if you have a patient that is coming from a lesser background, but is playing club or district level sport and doesn't have a lot of understanding, less education, and they just want to get back to playing quick. So for these patients, range of motion and weight bearing after a simple ACL surgery, how do you guide them? What are your targets?
Basically, their balance, range of motion and strength, these are the 3 targets. Those players we get it from Maharashtra Olympic Association. These are from the route places and remote places. So first we educate them regarding what happens to them, what is the nature, what is going to be a complication. So once you come to the complications, their antennas grows up. What happened next? What happened next? Then slowly you come with one complications which is going to be face them. So actually they start facing, because these players are really mentally tough, but whenever they comes across these kind of complications, problems, and their moral comes down. So as a physiotherapist, you have to guide them. Talk to your orthopedic surgeon also that so-and-so person is not able to immediately go for the operation by so-and-so reasons. There are many reasons basically. First reason is we all knows that affordability of the surgery and the time space. Basically, they also want immediately that sir also just mentioned that there is earning from their joints. There are few people who...
Suppose you have an athlete that really listens to you, but is going home and does very good homework. He feels that the more he does on his own, he recovers faster. So these patients generally at home also are trying heel slides on their own, wanting to sit and wanting to get range quickly. Suppose he comes back to you on day 7 post-surgery and he's showing, see, I have full range. So then do you progress to the next phase of rehab? How do you hold him down?
Our aim is to progress to the next phase of rehab, but with the bracing is important, and we do make understand then what is the importance of bracing also. Sometimes they are not also affordable to the brace also. So what we can give for them adjusting size, whether the taping will be used or whether some kind of other things which will help them, like their quadriceps strength, their hamstring strength, whether they have a good calf. Accordingly, we plan our rehab session further.
So you'll move the phases according to your understanding of the knee and not listen to the athlete much?
Yes, our understanding of the knee, because it's very important. First, we should understand what is the phase they are and then make them educated and understand. So there will be the less complication further when we are go to the next phase of rehab.
Right. Chandan, if you have a patient that says, I have all the money on the world, I stay at Malabar Hill, and give me the best brace possible after ACL surgery. I just want to start doing everything as soon as I can. So what kind of a brace do you advise these patients? Patients at around a month after an ACL surgery.
So basically, I am lucky enough to work with a lot of patients from the hospital and also from very well-renowned orthopedic surgeons. They actually come to me, like say at 2 or 3 weeks post, and they've already read up Google. Like they know everything. They know exactly which brace is coming next. So the first step for me is actually to understand the psychology of these patients. So I never treat one patient the same way as the other, because some of them are very scared, and for them we'll have to actually, really give a brace for a little longer. Some of them are overconfident. Again, we have to pull them back. Some of them are just fine, and we want to then follow the very basic framework. But because I work with so many orthopedic surgeons, and many of them actually come with a sheet of protocol, saying that they actually have a framework in mind, and I totally respect that.
Do surgeon protocols also mention the brace?
Yes, absolutely. So they have the exact timing of when they want to change the brace. So I totally respect it, because obviously they've actually gone in, done the arthroscopy, they exactly know what was inside. A very collaborative decision making with the orthopedic surgeon, me, and the patient. So
if the surgeon protocol says brace free at a month, and the patient reads Google and says functional brace from Donjoy or Breg has been advised, how would you say no, go brace free, or use the functional brace for activities?
So in that case, I'd really look at the ability of the patient and then try to explain to him. So if I see that he's very stable, then I can try and educate him, saying that, listen, we don't need this brace, or let's just wean it off gradually. So very, very shared decision making, because I end up seeing patients who already know a lot. Not necessarily right, but we have to respect their information that they have. So very shared decision making, also goal specific, what the patient comes with, like what's the goal. If we have an athlete, it'll be very different. When we have a housewife, very different. So more like we need the soft skills to understand the psyche of the patient.
Perfect.
Because
super. So Krupa, if you have a patient that's been operated, ghost surgery done, and the patients come to you and there's absolutely no protocol given at all, you don't know who has operated, plain ACL, what will you advise about range of motion targets? When do you want to achieve 90 and full range? When do you want to have the patient full weight bearing? And would you advise any brace?
Okay, so if there is no protocol by the surgeon, I think I would go more criteria dependent than time dependent.
Okay.
Okay, so if there is pain swelling, I would like to manage that first. If there is a good VMO contraction, if there is a good neuromuscular VMO activation, if he can do good SLRs without FFD, if there's no FFD, then I would like to start weight bearing as tolerated with the brace.
Perfect.
Then with respect to the next is what? ROM.
Yeah.
Yeah, ROM, I would...
Also as tolerated?
Sorry?
Also as tolerated?
Also as tolerated, because initially I do not like to push ROM in pain. We would want to let the graft heal. We would let, want to let go of the swelling and all of that. So ROM also as tolerated.
Fair. And brace?
In terms of bracing, I would honestly like to start if there is, the VMO activation is not very great. If the neuromuscular activation is not very great, then to just start with, I would like to go for a stiff knee brace or a long knee brace, because I don't want the patient to walk on a flex knee. And if he can activate good VMO in standing, there is good stability, then eventually shift him to a hinge knee brace.
A quick number game. Plain ACL, when do you want the patient to be brace free, walking normally? If not numbers, then what is that thing that you're looking for? ID first. Around what time? After a plain ACL reconstruction, brace free patient?
3 weeks.
3 weeks. 3 weeks. Chandan?
3 weeks I'd shift from a long knee brace to a hinge knee brace.
Okay.
Maybe a couple of weeks on the hinge knee brace, but varies depending on the patient.
And Krupa?
Mine would be around 3 to 4 weeks.
Fair. And any role of functional bracing, yes, no, after ACL, ID?
No.
Sandeep?
No, sir.
No.
No, if the rehab is done properly, no.
Close your ears, trade exhibitors behind. But there is a role and you have to try and see where the role is. Okay. Last question of the panel to ID. If you have patients who have undergone an ACL with a meniscus root repair or a bucket handle medial meniscus repair, I just want you to tell the orthopedic perspective to the rest of the audience in terms of weight bearing and range of motion for patients with ACL plus meniscus root repair or a bucket handle medial meniscus repair, this cohort.
So two different things, ACL with the meniscus root and ACL with the bucket handle meniscus. So first of all, I should be very sure how stable the fixation is. So we orthopedic surgeons always look for how stable the fixation was on table and the kind of repair I have done, whether it was different variations are there. So for ACL with meniscus, normally they are non-weight bearing for 4 weeks. And at 4 weeks, they start partial weight bearing with foot flat, not on the toes, with foot flat, partial weight bearing for another 2 weeks. And then at 6 weeks, full weight bearing. So some patients in which I have done a good bucket handle meniscus repair, which I feel is stable, and patient is doing well, again, I maybe slightly do it slightly early at 3 weeks, but not earlier than 3 weeks, because these patients have got some amount of pain and I don't want to give them pain. That's my answer. For the bracing, I just want to add on, because these long knee braces, they give you very deceptive picture. Most of the patients, they lie with their hip externally rotated and their knee is flexed. So we have to counsel the patient the toe should be facing towards the ceiling. So they have to keep their hip internally rotated and knee straight. And with the brace, you don't see anything, whether they have kept their knee flexed. So one has to be very careful using these braces.
You think the functional knee bracing with an extension lock work better to solve this problem? So if a patient has all the money in the world, maybe you could use one of these the functional knee braces and lock them in extension, and they allow less movements. So it would work better than a conventional sada long knee brace.
Maybe or may not be. It all depends on patient education and their literacy level and their understanding regarding the problem. That is, and for the athletes, they are very aggressive. So you have to hold them, be very slow, don't be very aggressive.
Perfect, perfect. I think we covered a good few points. So, Chirag?
So I have a question here. See, I always brace my patients, okay?
Right.
Irrespective. Now, how many of us have seen a good quad control without an inhibition on day one, post any surgery?
No. So I think in general, I think all of us concur that initial 2 weeks bracing is needed, because our patients aren't intelligent enough to work with a knee where the quadriceps is not firing much and not buckle.
Yeah. So
right?
second question lies here. We are talking about the timeline of like 3 weeks, 6 weeks post surgery, give off the brace. So let me make it very simple. For me, if a patient is able to straight leg raise 100% without a lag, that means he's got a grade 4 of quadriceps.
Correct.
Second, if he's going to lie supine, with the full extension of the knee. Now, if a patient doesn't have a full extension, he is not locking, he is going to buckle.
Right.
If he is not going to do an active SLR 100% with good quads control, again he is going to buckle. So how are you going to prevent this without bracing?
Right, right. So it's important that the patient has great quadriceps control before you make them brace free. So in conclusion, range of motion you can push to as per the patient's tolerance. Don't push much, let the patient achieve it. As far as weight bearing is concerned, also it's as tolerated, but be very wary of certain types of meniscus repairs. Make sure that you talk to the orthopedic surgeon about them. And for the bracing bit, have an extension brace in place possibly for the first 2 weeks. Post that, you see how the quads are and then decide for yourself if further bracing is needed. Right, with that we'll conclude the panel. Thank you so much.